Thank you so much, Dr. Anshika. And thanks, Dr. Rohan, Dr. Pooja, Himanshu sir, and RSI for this wonderful opportunity. Okay, so we all know that cataract surgery in the presence of glaucoma poses certain challenges that need to be addressed to offer the maximum benefit without complications. And a growing body of evidence supports the view that cataract surgery lowers IOP in patients with narrow or closed angles, as well as in those with open angles. So, if you look at the mechanism of IOP reduction after phaco surgery in open angle glaucoma, there are various mechanisms which have been proposed. According to Johnstone theory, after cataract surgery, the anterior capsule, there is a posterior displacement. So the posterior traction of the zonules, it leads to the ciliary body and scleral spur to move posteriorly, which expands the trabecular meshwork and Schlemm's canal, and this improves the aqueous outflow. So that is the reversal of the aqueous pump failure. This is one of the theory which has been proposed. And other theories which are proposed are the inflammation-induced morphologic changes in the trabecular meshwork, just like the effect of laser trabeculoplasty, or there is remodeling of trabecular endothelium secondary to ultrasonic vibrations. So if you look at this study, the ocular hypertension treatment study, which was published in 2012, and it showed that there is an estimated mean decrease in IOP post-operatively in the cataract surgery group, around 4 millimeter mercury, as compared to the control group, which had very slight mean decrease in IOP of 0.3 millimeter mercury. So in the majority of the patient, there was a mean post-operative IOP decrease. But the thing to we look in this, from this study is that in 11% of the patient, they may be that IOP increases from pre-operative levels. So we need to be careful in 11% of the patients. So we need to be careful and tell our patients about this. This is another study which looked into the IOP reduction after phacoemulsification and IOL implantation in glaucomatous and non-glaucomatous eyes. And it showed that the IOP reduction was proportional to the preoperative IOP. The highest preoperative IOP decreased the most, and the lowest is increased slightly. And 1 year IOP reduction was sustained for 10 years, and it was similar in patients of all ages. So it concluded that IOP reductions were similar to previously reported reduction in non-glaucomatous eyes, indicating that the crystalline lens may be a major cause of ocular hypertension and glaucoma, and phaco with IOL implantation may help prevent and treat adult glaucoma. If you look at the mechanism of IOP reduction in angle closure glaucoma patients, IOP lowering effect of cataract surgery is tend to be much more greater in patients who have angle closure glaucoma because of the fact that there is a reversal of the pupillary block or the angle crowding which occurs in the angle closure patients. So this was a study, randomized controlled trial, the EAGLE study, which was a very robust study. It studied the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma. So it was they approached to treat the primary angle closure or primary angle closure glaucoma patients with either clear lens extraction or the standard of care, that is the laser peripheral iodotomy and stepping up the medical therapy. So patients of 50 years or above were included, and who had IOP more than 30 millimeter mercury were included in this study. 155 patients had primary angle closure and 263 had primary angle closure glaucoma. 208 underwent clear lens extraction and 211 underwent standard of care treatment. So the IOP was 1.1 millimeter lower in clear lens extraction patient. So this study concluded that clear lens extraction showed greater efficacy and was more cost effective than standard of care or LPI patients and should be considered as first line therapy. There was a study by Lam et al. For acute angle closure glaucoma patients and who had angle closure along with cataract. They also showed that phaco is a great option. So phaco patients, they had lower IOP, less medicines were required, and they had better visual acuity. Another study on chronic angle closure glaucoma also showed that phaco had a good effect. So if we look at the flow chart and the decision making which we arrive at in cataract surgery indicated patients of glaucoma. So this was the flow chart which was published in 1986 by Shields, and this is the flow chart given in 2013. So we see that in the patients in which cataract surgery is indicated, if the patient has well-controlled IOP or a borderline IOP, the more and more surgeons, they are going toward cataract extraction alone and or cataract plus surgeries. Only in the uncontrolled IOP patients, the two-stage procedure is required, or if there is an urgent need to restore vision, a combined procedure may be planned. So what evidence-based medicine teaches us is that phaco alone as an IOP lowering procedure should be considered in all patients with glaucoma and visually significant cataracts. And phaco alone and itself is a viable first-line surgical option for narrow-angle glaucoma. And phaco is also a viable option for controlled glaucoma on 1 to 2 medication. It improves vision and good chances of getting off one drop also. Only in the setting of uncontrolled glaucoma with open angles, more and more evidence is evolving that either we should do phaco or we should do sequential surgery in these patients. So what are the considerations before cataract surgery in glaucoma patients? Many of patients with glaucoma, they think that cataract surgery will reverse their visual field loss. So it is essential for surgeons to set realistic expectations in those patients. It is also important to explain the choices of the IOL in advanced glaucoma patients, like multifocal IOLs, EDOF IOLs. They further reduce contrast sensitivity and they may result in the suboptimal outcomes. So these should be avoided. But toric IOLs can be used in these patients. And even an insignificant cataract can greatly reduce visual acuity by decreasing contrast sensitivity. And several studies have demonstrated that patients with glaucoma experience a significant improvement in visual function and quality of life after cataract surgery despite visual field defects. So if we look at the cataract operation and IOP, intraocular pressure, they may be intraoperative effect, short-term post-operative effect, and long-term effect, which we need to take care of. And if you look at the intraoperative effect on the IOP, every 15 centimeter of bottle height above the patient's eye level, it increases 11 millimeter mercury of IOP when we go with the phaco handpiece in irrigation only without aspiration. So if the bottle height is 100 centimeter, the IOP can reach as high as 70 millimeter mercury, which is around the closing pressure of the central retinal artery. So particularly in the eyes with end-stage glaucoma, this could lead to a severe vision loss or what we call wipeout syndrome. So we should always be careful that keep the bottle height low, keep the pressures low in these patients. The short-term post-operative effect on IOP may be there because of the retained viscoelastic, which is the most frequent cause. So we should always try to take out all the viscoelastic at the end of the cataract surgery. Then surgical trauma, prolonged surgery, retained lens debris, inflammation, hyphema, PCR, vitreous prolapse. These factors can also lead to short-term post-operative effect on IOP. So immediate post-operative spikes usually happen 4 to 12 hours post-operatively. So there were various studies which was done to look at the effect of the IOP changes in the IOP after cataract surgery. So in a study of eyes without glaucoma, IOP spikes of up to 68 millimeter have been observed, where 8% of eyes develop spikes of more than 40 millimeter 4 to 6 hours post-operatively. But most of them, they come to normal up to 20, in the 24 hours. So IOP spikes over 30 millimeter were found in 13% of eyes in one of these study, 1 day post-operatively in eyes of with primary open-angle glaucoma, and which was higher than found in the non-glaucomatous eyes. In another study that set threshold at 28 millimeter mercury, the 46% of glaucomatous eyes had high IOP as compared to non-glaucomatous eyes. And among glaucomatous eyes, some patients are at increased risk of the higher IOP. Patients who have higher axial length and deeper anterior chamber that had required increased number of anti-glaucoma medications pre-operatively, and those that had required pre-operative laser trabeculoplasty. And this is very interesting study in which oral acetazolamide administration, they studied the effect that if given 1 hour pre-operatively, it significantly reduced IOP elevation from 1 to 24 hours post-operatively. And if you give 3 hours post-operatively, it reduces IOP elevation at 5 hours or more after surgery. And there may be chances of late post-operative risk of IOP rise after cataract surgery due to steroid use after we do cataract surgery. So mostly myopic eyes are steroid responder, but there can be other people who are steroid responder. So meaning their IOP may raise 10 days to 2 weeks after cataract surgery after starting topical steroids. So you need to be careful and monitor them closely. If you look at some surgical technique consideration, in primary open-angle glaucoma, there are no spatial technique modification are needed usually, but cases which are terminal stage glaucoma patients, we should avoid increasing the intraoperative IOP, as I mentioned before. And in view of possible surgery, filtering surgery required later on, all our incision should be in the clear cornea to avoid damage to the conjunctiva. In pseudoexfoliation glaucoma, surgery may be demanding because of zonal instability and because of poor pupillary dilatation in patient of pseudoexfoliation. So we may need to use rings and hooks in these patients. And one tip is in pseudoexfoliation glaucoma, you should always aspirate the exfoliation material from angle at the end of surgery which may be beneficial for post-operative IOP spikes. If you look at angle closure glaucoma patients, surgery is always challenging because of anatomical characteristics of these eyes. So, effect of glaucoma and previous attacks of acute angle closure are also there in these eyes. So, they have shallow chambers, which complicates all surgical maneuvers, and it's often prone to intraoperative choroidal effusion. So, pre-op in these patients of angle closure, preoperative mannitol may be given to, they decrease the IOP, or preoperative estrozolamide should be given, and care should be taken to construct wounds properly to avoid intraoperative iris prolapse. And patients, if they have extensive antiasynecia, cataract surgery can be combined with goniosynostosis to separate the antiasynecia from trabecular meshwork. So, in general, cataract surgery has been proven to be a sufficient first-line treatment for angle closure glaucoma. It's more effective than laser iodotomy and could be considered as an alternative to this. If you look at the surgical consideration in patients who have undergone past trabeculectomy, we all know that the faking patients with a functioning trabeculectomy, almost 50% of the patients they have significant cataract over the next 5 years and they require cataract surgery. Hussain et al. Has showed that early cataract surgery has high incidence of trap failure. So we should consider a period of 2 years gap between the two operations, which is the safest option for these group of patients. If you look at postoperative inflammation, which is induced by phaco, is the main factor which leads to blab failure. So we should always try to do surgery in a traumatic way. We should try to do minimal manipulation. Try to avoid, of course, we need to avoid the blab when we are making our main port incision or side port incisions. Always go through clear poly incisions, maintain anterior chamber stability, no fluctuation should be there. And in case of a malfunctioning blab, a combined blab revision approach can be considered. And we need to go for aggressive anti-inflammatory treatment intra and post-operatively. So to conclude, cataract surgery plays a role in IOP reduction in open angle glaucoma and angle closure glaucoma. And with the increasing availability of mixed procedures, surgeon managing patient with concomitant glaucoma and cataracts have more options for surgical IOP control prior to offering traditional glaucoma filtering surgery. Both cataractus and clear lens extraction can be considered in the management of primary angle closure and primary angle closure glaucoma, as it may be curative if significant trabecular dysfunction and glaucomatous optic neuropathy have not yet developed. And technological advances have improved the safety and outcomes of cataract surgery on patients with advanced glaucoma. We can maximize success requires through good preoperative examination, careful surgical planning, and discussion of both the risk and benefit of surgical intervention and setting realistic expectations. Thank you very much.
Thank you so much for your valuable talk, sir. Sir, I had a quick question. If the patient is a glaucoma suspect, if there's a family history or some disc changes are noticed pre-operatively, would you consider doing a peripheral iridectomy during your cataract surgery?
The patient has open angle glaucoma or
Yes, sir. Open angle.
Yeah. I don't think it's required. Yeah.
So even if
Not
he's a
required.
suspect or, you think that his pressures are moderately 22, 24, and
So as I showed a lot of studies, and we all know that doing phaco itself is a mixed procedure. It decreases pressure by 2 to 4 millimeter mercury. So that is not required in the cases to do peripheral iridectomy. It doesn't have, I think, any role.
Another question that I had in mind, sir, just wanted to ask you.
Yeah.
Patients generally, they come to you, say, with an NS3 cataract with a history of glaucoma, say a 0.6, 0.7 cupping on the disc. You don't know what percentage of vision loss is because of the disc, what percentage of vision loss is because of the cataract. So
Yes.
what do you promise to that patient? Like, what do you say to that patient? How much recovery will be there in the vision? Like giving some counseling tips for the youngsters. I think I picked up on that point of yours that, you have to be very guarded in such patients. So how would you approach?
Yeah. So see, we should, as we all know, we should always under promise and over deliver. So we should always set the expectation to be realistic. That patient should know that, of course, he has that disease. If he has all the records available, like what all damage is already there, if he knows about his disease, then it's very easy to make him understand that glaucomatous damage is always there, that peripheral damage is there. So we are going to improve his vision. But as a lot of studies are there, there are a lot of advantages which we tell to patient that firstly, all our diagnostic accuracy and everything improves once we take off the cataract. Our perimetry, OCT, everything, becomes better, and their reliability becomes better once we take off cataract. Of course, vision also improves. So it's very easy to make patient understand. If he doesn't have any records available with him, any fields, or he doesn't know about that, only we have diagnosed that yes, he has this damage also. So of course we need to tell patient that, see, whatever we are doing, we are taking off cataract, putting IOL, then we need to do all the tests properly to see whatever damage is there, and we need to continue with the glaucoma medication if required.
Right. Dr. Mehta, sir? Yeah.
Yes,
Harshul, thanks for a wonderful explanation about the subject. The whole lens iris diaphragm, once it goes down following cataract surgery, reduces the pressure by itself so beautifully. If you have a patient who is fairly decently controlled, not terrible field damage, good compliance, 30 pressure, you've done your cataract, would you do a trap together within such patient? What would you do for a patient of this? When would you do a trap? Indirect. The other question is, what is your cutout criteria? When would you do a trap and cataract together? And when would you, the fact that you remove the lens and you remove that, your pressure, how much do you expect it to go down?
As I said, nowadays combined surgery are reducing, day by day, because we all know that combining trab and phaco gives suboptimal result as compared to if you do a trab in a pseudophakic patient. So if pressures can be controlled medically, so my first preference is, of course, will be do cataract surgery, put him on maximal glaucoma medication, wait for at least, as much as I can, like 1 year, maybe 1.5 years. So I want to separate the two surgeries as much as possible. So that is my goal.
I think I'd like to add something. Can I do that?
Yeah, Dr. Priya.
So I think that was a very tricky question Dr. Himanshu has put forward to everybody, that what you are going to do in such a case. I just have one point to add, that maybe additionally, I would look into the details of the past, what the patient had, and whether the patient has been documented to be having the progression of glaucoma. If it's a documented case of progression glaucoma coming up with a cataract which needs to be removed, probably I might consider, because at this point of time it's not only the pressure that is being taken into consideration. So maybe this is a kind of patient whom I would take for both the surgeries, I mean the AGS along with the cataract surgery at that point of time, taking into consideration that it has been a documented case of progression of glaucoma over a period of time. But as Dr. Harshul said, that if you have a case suddenly coming up in front of you and you are diagnosing him with pressures and you do not have any history, probably look into the other eye, what the other eye speaks. So taking into consideration what's the status of the other eye, then comes the decision making. So actually, it's a very complicated thing, you need to have so many criteria coming up, not a single case which comes, it's a whole entity of glaucoma with cataract, and how the patient comes up. Many other factors are there in glaucoma which needs to be taken into consideration. So I think, and quite a bit of it is also surgeon dependent. It's surgeon's choice also many times, it's not just that we have a clear-cut rule that yes, we are going to, if this is 1, we do AGS, if this is 2, we do cataract. We don't have any such norms like that. So I think it's much more surgeon dependent also, and also how are the results in the hand of a particular surgeon. Me operating would be somewhat different than what Dr. Harshul is doing, and what Dr. Harshul is doing is something different from what Dr. Himanshu Mehta does. So that variation will always be there in the surgery. So I think, yeah, it's quite a bit of a challenging task, that I would say.
Dr. Sood, would you like to comment something on this?
Sure. So I just have two things. There was one question that Rohan asked with the nuclear sclerosis cataract, and there was one question which Dr. Mehta had asked. So which one are you wanting me to?
Both, sir.
So Rohan, can you repeat your question once, because some of the parameters may need to be re-emphasized. Could you repeat your question?
I said that, for example, a patient comes to you with a grade 3 nuclear sclerosis and there is a CDR of a 0.6, 0.7. Patient is not on anti-glaucomatous medication. You have to operate this patient. Now, first you'll go ahead and do the cataract surgery. So what promise would you give to this patient that what is the vision that will be restored? Because you don't know how much of the vision is gone because of the cataract, how much of it has gone because of the glaucoma.
So why would there be a hesitancy in your mind to promise the patient a good vision? Because the question here is, why are you operating? Are you operating because of a 3+ nuclear sclerosis and hardening of the lens, or are you operating because the vision has decreased? You can have a 3+ nuclear sclerosis and have good vision. Now, the next step would be, what is the patient's vision and can he do a visual fields? If he does a visual fields, remember that the fields, that's the total deviation plot and the pattern deviation plot, give you the answer as to what is the generalized depression and what is the focal loss. So if this 0.6 disc could actually be normal also. You cannot comment on the pallor of the optic disc because of the nuclear sclerosis affecting the color change of the optic nerve when you visualize with your 90 diopter lens. So one of the good things here would be make sure that the chamber is not shallow. Do a gonioscopy. I assume because you're suspecting a glaucoma, make sure the visual fields have been done. So if the visual fields are done and they are normal, I would be very confident in telling the patient, let me do the cataract surgery and your vision will come back very nicely. I'm fairly confident, provided other factors are not there, because you may not be able to make out a macular degeneration or something. Look at the other scenario. So does this answer your question? If
yes.
I would, from a prognostic point of view, very good prognosis for this patient from the data that you have made available. What was the other question that Dr. Mehta had asked?
My question was, sir, you have a patient who is glaucoma controlled. The pressure was always between 25-30, never really went to 40-50. And you remove the cataract, you expect the pressures to fall down. In a 28 pressure who was well controlled with your target pressure around 16 post pre-op, you do a cataract. Would you do a trap together with it, or would you not? When would you do a glaucoma surgery together with a cataract?
So as a generalization, you have put two scenarios. One is where you said the pressure is all right and it's in the range of 25-30. And the second patient is where you said it's 15-16, right? Correct me, Dr. Mehta.
Yes, sir. Yes, sir.
So if we look at that pressure of 25-30, I would need some more information. Can you visualize the optic disc?
Yeah.
I'm not happy with the pressure of 25-33. I'm not a cataract surgeon, but even as a glaucoma specialist, if I was to advise a cataract surgery, I would not. I would be very hesitant to plan only a cataract surgery. Perhaps the only situation would be patient cannot come back for a second surgery. Patient has multiple problems where a second option is not available. But my first aim would be 25-30 is a pressure I'm not comfortable with. And if it's with more than two medicines, I would plan for a cataract and a glaucoma surgery together for this patient. The other reasoning could be, I can see the disc or the past fields or documentation shows that there is a advanced glaucoma. Then again, I would individualize. Can the patient take up two surgeries, or should I do a glaucoma surgery first and follow it up with a cataract surgery? So my thought process would be slightly different from what has been mentioned for this 25-30 patient, because 25-30, even for a patient with a normal disc, is not a good pressure to have. And I would definitely do a gonioscopy to make sure that angle closure is not something that we are looking at. A PI would be mandatory if angle closure is there. So that is, but the other question was about a patient with a pressure of 15-16. We don't know the status of the optic disc. But 15-16, well controlled with medication and a disc which is moderate, the thought processes have changed from cataract surgery, cataract ECC, IOL, and phaco surgery. So 15-16 and say one drug and a 0.8, 0.9 disc may just get away with a good phaco surgery where manipulation is minimal. But if you feel that the pupil is myosed and there will be a lot of manipulation and the iris pigment release can go on to block the trabecular meshwork, you might say, well, post-op rise in IOP is more likely because in a patient who has an advanced glaucoma, so I'll do a combined procedure even for the 15-16. But somebody might argue and say, well, I think a cataract surgery and medications post-surgery would suffice for this patient. So these are options that you can keep in mind. But again, they're not a cataract surgeon's viewpoint, they're a glaucoma specialist viewpoint, pure glaucoma specialist.
Great. Thank you so much for the insight, sir. I would like to introduce Dr. Gaurav Luthra, who's just joined us. He's Chairman ARC IRSI, and I have one question for him. Would you do FLACS, sir, in a glaucoma patient, considering that there's a sharp rise in IOP when you put the cone? And secondly, would you also offer a multifocal lens to a glaucoma patient?
Sir,
you're on mute, sir.
So you're on mute.
Right. Sorry about that. I'm so sorry I couldn't join before. There was a miscommunication. I kind of thought it's tomorrow, and I was not prepared to join today. Anyway, thanks Rohan for calling me up and asking me to join in. And so good to see all of you, dear friends, everyone. So the question is nice, Rohan, and I routinely do. Frankly, there are a few indications where I don't mind doing FLACS at all. It's a temporary increase in pressure, but somebody with a very, very small island of vision, or somebody who has a very kind of a little bit of optic nerve head, function remaining, I would be hesitant to cause any kind of IOP spikes, which you might see with FLACS. But otherwise, if somebody has minimal field effects, I would, not hesitate to do FLACS. In fact, in small eyes where the chambers are very shallow, intumescent cataracts, or even with the chronic ACG or something where you have a very shallow chamber, I would actually encourage the patient, if the pupil size allows it, I would actually encourage the patient to go for FLACS, because rhexis complications will be much less. With the eyes which are having very shallow chambers and all, you can have problems during rhexis with upthrust and everything, and FLACS offers a good option there. And as far as multifocal lenses go, if there are field effects, I would definitely not think of a multifocal lens at all at any cost, and I would totally stay away from that.
Dr. Sood, sir, with your experience in glaucoma, have you seen multifocals being implanted in glaucoma patients?
I have seen, but what I would actually say is that patients who have advanced glaucomas definitely avoid multifocals. And as Dr. Luthra said, field effects correlating with the optic disc change, something, an inferior scotoma or inferior hemispherical defect, superior hemispherical defect, always good to avoid because they'll be unhappy in the long run. Ideally avoid unless the fields are normal and the pressures are controlled and you're not looking at much in terms of a glaucoma surgery. You can think in terms of a multifocal, but otherwise, as a general rule, if there is glaucomatous damage, avoid.
Okay,
In
thank
fact,
you.
Pooja,
Yeah.
I'm so sorry I'm
No,
jutting
no,
in,
no.
but I don't know, and I joined late, so maybe you've already discussed all this. But I find cataract surgeries with operated glaucoma, patients with with big blebs and very shallow chambers and all also quite tricky. Have we discussed cataract surgery in patients with big blebs and glaucoma filtering surgery done and shallow chambers, and sometimes it becomes a little challenging. So any thoughts on special precautions required for those patients who are like with a filtering bleb and are undergoing a cataract surgery after that? There are challenges. Sometimes these cataracts are more likely to be there. Supposed to be pupil issues, and they can even be, sometimes you'll find a subluxated cataract, loose zonules and stuff. So Dr. Himanshu, I'm sure, has encountered quite a few of these, and Harshul, all of you, in fact. Any thoughts on that?
Harshul is the expert today on this. Harshul, the ball is in his court.
No, we did discuss a little bit about those because we need to have different session for entire to show surgical videos. No, the time was limited, so we couldn't show the videos which I wanted to show. Actually with the large blabs, and we are doing cataract surgery and small pupil pseudo exfoliation using rings and hooks and everything. So, of course, these cases they become very tricky sometimes. Because of posterior synechia and close narrow angles, all your maneuvers become difficult because chamber is very shallow. So, Rohan, we need to have one session on.
I think that we can keep that for another day when we have a full session to that.
Yeah.
So Ron, you already had one on field changes that Dr. Tuli spoke about.
Yes.
That would be very interesting to learn about field changes, various cases that are there. A lot more emerging. How smaller sessions you'll have further now after this.
Yes, sir.